Good afternoon again, everybody. This is Phil Gibson with People Care Health Services. We are very fortunate today to have Sharon Denny and Bridget McCabe with us today to talk about frontotemporal degeneration. Sharon is the Program Director at AFTD and leads the support and education efforts for people with FTD. That's frontotemporal degeneration, their families and healthcare professionals. Her priorities include ensuring the responsiveness of core services and expanding the availability of FTD-specific resources and supports. She has introduced initiatives that address the needs of the children and teens and individuals diagnosed with FTD. For the past 6 years, she has led a committee of clinicians and family caregivers who produce Partners in FTD Care and FTD Education Initiative for community healthcare providers. Ms. Denny has a master's degree in clinical psychology and more than 26 years of experience in the program development for disability organizations. She has been with AFTD since September of 2008. Bridget joined AFTD as their first support services manager in May 2015, and she works collaboratively with AFTD staff and volunteers to manage a national network of FTD-specific support groups across the U.S. And we'll get a chance to hear more about that towards the end of the conversation. Ms. Moran-McCabe holds a master's degree in public health and has 14 years of experience in developing new programs in the fields of hospice, palliative care, mental health, research, and community health. Ladies, we welcome you to the Community Connections with People Care, and we can go ahead and start the presentation. Thanks a lot for joining us.
Thank you.
Great, thank you. So I'm just going to start off with a brief orientation on dementia and then kind of narrow things down to some of the clinical features within FTD and how they differ from kind of the more known type of dementia, which is Alzheimer's. So there we go. So dementia overall is a global term that speaks to changes in thinking, behavior, or emotions, and particularly, as this is quoted here, it's a condition of the mind caused by the disease of the brain. There's many medical conditions that can cause dementia. Some types of dementia are, they can be curable or will stop progressing over time, and others continue to progress over time, such as the type that we're talking about today, which is FTD. So it's a neurodegenerative and it is progressive disease versus the larger scale of dementia that hosts many different types. So we're going to switch now to a video, and this will be showing, it's taken from our annual conference, and so some of the details are no longer relevant. However, the overall concept we hope will just share, what it means to be living with FTD. So Susan Sushin is the person's name in the video, and she's a person diagnosed with FTD, and this is a little bit about her story.
My name is Susan Sushin. I'd like to welcome everyone to this year's 2016 AFTD Educational Conference. I'd like to tell you a little bit of my story. I was diagnosed with FTD in 2013 after several falls, legs not working. I could not understand why. Too much stimulus can make me very, very confused. And noise is near frightening to me. Apathy is a part. Inability to speak correctly and walking are my major symptoms to date. I think the biggest disappointment or fear is the loss of what I have always stood for, who I am, what I like, what I know like. I don't know anymore. We really have a great opportunity today to be surrounded by research scientists, medical doctors, care partners, and those living with the diagnosis, all moving towards understanding, recognizing, and working towards a cure and modalities to help those living with the diagnosis have quality life. I think it's really important that we all work together collectively so that we are all on the same page, working together. The lived experience takes us beyond the laboratory to the everyday. And every day, people are being diagnosed with FTD and are learning how to live. We can share that experience in the hopes of making life better for those behind us. And it does make me passionate about using my voice, everybody's voice with FTD. Because although the symptoms may sound similar, they're not for everybody. So you can't just label it and mark it and say that do one thing and it work for all. We must include all our voices, all of the nuances together to help bring a cure and a better understanding. Thank you for listening to my story, and thank you to the AFTD for bringing us all here together today for a wonderful opportunity to learn and share as a community for the better of everyone.
So just to broaden out the conversation a little bit back to all the different types of dementia, where and what part of the brain that the disease is in distinguishes what type of dementia it is and what the symptoms are as a result of that. So not all dementia is caused by Alzheimer's, and this graph just pulls out a little bit of all the different types of dementia. And as you can see, the light blue sliver is FTD, and the estimates are rough here, but we think that the cluster of FTD diseases, again in that light blue sliver, are about an estimated 10 to 20% of all types of dementia. However, the biggest square is still that Alzheimer's dementia that's in the blue, the larger pie there. And so one of the things that I wanted to make sure we did was kind of talk through what the differences are between FTD and Alzheimer's. And so basically with FTD, again, it's a cluster of diseases, and it primarily is a either behavior, language, or motor disorder to start. And we don't kind of have any treatment options currently for it, but and based on that, we know that it so the lifespan is about 7 to 13 years. However, one of the major other differences between FTD and Alzheimer's is that it's an early onset type of dementia. So 40 to 60 years old is typically when most folks are diagnosed, which is also typically the prime of their career or their lives. And so most people don't actually suspect that it's FTD to start because the persons who have those symptoms are so young. And then it's also pretty rare. So comparatively to Alzheimer's, which we'll get to in a moment, about 50,000 folks in the US are affected. And again, that's a rough estimate, but so comparatively to Alzheimer's, there's more than 5 million that are affected. Some of the other differences within Alzheimer's is it's primarily a memory disorder. So it's located where the disease is happening is in the back of the brain near the memory center. And the onset is a lot later. So it's usually 60 to 80 years old where folks are majoritively diagnosed. And then again, the average lifespan is 8 to 10 years old. 8 to 10 years lifespan after diagnosis. But there are some pharmacological pills and medications that can prolong that, depending on when people get started with that. So some of the main pieces to FTD, again, are those three main categories in terms of the symptoms. So instead of memory like Alzheimer's, we have these three. So behavior changes, language changes, and motor changes. And the behavior changes in particular do progress over time, and so they can change and lead individuals to not really knowing that there's any neurological problems. We often hear from families that the first signs are often feeling like symptoms that mimic stress or depression. And so again, that theory of a midlife crisis, it's coming around the same time frame that folks would be experiencing those other pieces. And so from that perspective, it does make it a challenge to figure out exactly what's going on. And we often hear that the misdiagnosis is pretty high. So some of the behavioral changes, as you can see here, apathy is the first one, and that's typically the one that is the earliest and most predominant of all of the symptoms. And then it's also one of the most difficult to manage. So along with that is that loss of empathy. So some examples of that is, let's say there's a funeral or someone in the family gets sick. The person with FTD doesn't necessarily react to that in a way that they used to or in a way that's appropriate. So lack of emotion, lack of understanding, that anything has changed, not really caring is what it looks like, but it's just because the part of the brain that does that for you is what's being affected. So some other issues include the inappropriate social behavior, some rituals or competitive behavior, so things like kind of uncharacteristically rude comments or, not having the right table manners that you would expect from an adult, or some of the rituals, counting coins or sorting things, kind of doing things over and over again, including their routines. So needing to have a walk at the same time each day, needing to eat at the same time each day. Some of those are indicative symptoms for that piece. And then there's also the mood changes and the decreased self-awareness. So that can be pretty erratic at times, and because of the decreased self-awareness, it means that the mood changes can really be fluctuating. And so things like, lashing out in anger or at something that really doesn't warrant that, or just being sometimes paranoid or things like that can be happening. So with the language changes, this is another piece of FTD that most people experience, where either their what's coming in from the outside world in terms of language isn't getting translated correctly in their brain, and so it kind of word retrieval and the word meaning coming in doesn't necessarily compute anymore, as well as words that are trying to get out. So it makes speech a lot slower. It kind of makes it more of an effort to be able to talk about things that they are in their brain completely aware of. So they know what the word is that's happening in the brain, but it's just not computing out into the world as it should. And then the last major change are the motor changes. So things like slow and stiff gait and movement. So basically any issues with how they're walking can be affected, as well as their balance, so that instability. And those are Parkinson-like disease symptoms as well, and again causing confusion in the diagnostic world, so difficulty with that diagnostic piece. There's also some swallowing difficulty that can happen, and can be a real problem with that. And that can also, switch into things like the ALS side of FTD. So there can be a dual diagnosis with ALS and FTD. And with that, you get the swallowing if it's a certain type of ALS, or the rigid muscles and kind of that paralysis that starts to happen. So the other piece to the motor changes are some up and down eye movements. So some folks aren't able to look below a certain point anymore, depending on what those symptoms are. And I think that hardest thing to kind of grasp in all of this is it really can be a combination of any parts of these symptoms, which again, it stems from all different parts of our lives. So whether you're doing, you have language, but you're saying inappropriate things, or you don't have language and you're getting frustrated and kind of acting out, as well as some of those motor issues. So it is really difficult to kind of understand what's going on there. And so digging a little bit deeper into kind of what this all looks like. So this is the spectrum that we talk about, or this cluster of diseases. I'm going to go through the names of all of these, but basically these are what encompass the overall idea of FTD. And so on the right-hand side, the progressive supranuclear palsy, that's a movement type disorder, as well as the cortical basal syndrome. The language diseases are in the middle there, so letting go of the acronyms for a moment, the logopenic variant of primary progressive aphasia is there on the second, on the right there, and then up at the top there's the non-fluent agrammatic variant of primary progressive aphasia and the semantic variant of primary progressive aphasia. They're all language, and again, it's just a matter of sorting out if the issue is that the language coming in is being distorted or the language going out due to the dementia. And then kind of off to the left there, that's the most prominent type of FTD, so this behavioral variant. And as the name suggests, that's the one that has some of those issues such as the apathy and mood swings and things like that. And then, like I mentioned before, on the other end of the spectrum is this combination of having the ALS or Lou Gehrig's disease along with the FTD. So all very complicated diseases in and of themselves. And then you kind of are clustering all of them together that just create, some difficulties in terms of really understanding what's going on. But the one thing that we know about, so in the brain that's in the middle of that rainbow, is it's highlighted there what the darker parts of that brain are, and those are the frontal and temporal lobes, and that's where the disease tends to be. So what we know about all of these clusters is they all start there, and so from that perspective, it's really showing how they all are clustered together, even though their symptoms all look so different. So as I mentioned before, it is very difficult to diagnose FTD, and again, because the symptoms do resemble a bunch of other disorders, and they also change over time. So because it is progressive, it can move into starting off with a behavioral variant and moving more into language or the motor issues as it progresses. And so there is also the issue is that we don't have any way to tell exactly what the disease is until after death with an autopsy. And so from that perspective, really understanding on a clinical level what's happening, it has to do with people's personality. So as someone's personality is different from everyone else's in the world, those changes can sometimes be pretty subtle. So it does lead to a lot of frustration from that perspective. So on this screen, we also have ways that they do diagnose on a clinical level, and which means that while the person is still alive and we can't do those tests in the autopsy, we kind of make guesses based on some scans and other ways that that we learn about the disease. So the person diagnosed may or may not have any insight that this is even happening, so they aren't aware of the changes sometimes. And so we do rely a lot on families and friends to be able to share kind of what those changes look like. We also rely heavily on imaging of the brain, and here are some examples of what that can mean. And then we also do some neuropsychological testing. And so the person diagnosed, it means a few hours worth of testing to get the diagnosis. And sometimes, as Susan said in that intro video, it can be overwhelming to get stimulated and overly stimulated with all of these questions, and so it really does make diagnostics incredibly difficult. And then the last piece that I'm going to talk about is around how FTD affects the social brain. So things that we're used to doing every day is exactly where it's affecting. So Alzheimer's, again, is more around memory, so things that have happened in the past. This really attacks things that we need to do every day, so that some of those executive functioning pieces, and we have some examples of what that means here, but it really is the person's diagnosis, the person's personality that's affected. And so caretakers can often be hurt or frustrated by what they're seeing, and their spouses or family members or friends aren't really taking interest in their lives anymore, both their own and that of their family and friends. And so it can be an incredibly hurtful process for caregivers until they realize, what exactly is going on and that the person really can't help it. So I'm just going to turn things over now to Sharon, who's going to talk a little bit more about the experience of FTD, now that you have a little bit of an introduction to, the disease itself.
Oops. Great. Thanks, Bridget. I appreciate it. There's, as Bridget outlined, there's a number of ways that FTD is different from Alzheimer's, and some of those combine to really distinguish the experience of FTD as bringing with it a lot more challenge for folks. And so I wanted to just highlight some of those things that really characterize the experience of FTD, both for the person diagnosed and for their family, and then talk a little bit about the importance of having resources and supports that are tailored specifically to this type of dementia. So the three things that really characterize FTD are that it's less common. The best estimate that we have for the prevalence of FTD in the United States is about 50 to 60,000 people diagnosed. And I do want to caution folks, that's a pretty low number. We know that FTD is far less common than Alzheimer's, but it's still very, very difficult to get an accurate epidemiological study done because we aren't able to diagnose these diseases definitively during life. And so there is an understanding that that estimate of 50 to 60,000 people affected is probably an underestimate, but this is the only number that we can support through the studies that have been documented to date. We believe it to be much higher. It's important to realize, though, that in the US we've defined a rare disease as something that affects 250,000 people or less. And so in that regard, FTD is still considered very definitely a rare disease by that definition. The second piece is that the symptoms are poorly recognized by the public and very often by doctors and healthcare professionals, and that the symptoms are not understood. So as Bridget mentioned, we're talking about symptoms that are not memory related. They are happening in a younger person. The symptoms start very gradually for folks and are often misunderstood as being psychiatrically, related to psychiatric disorders or being related to normal aging or to relationship issues. And so the experience of developing this disease or being a close family or friend of somebody who's developing it is that there's a lot of confusion. This is happening and not being explained or understood. People find that the behavior and the personality of their loved one is changing from somebody who maybe has been working at a very high level in a very accomplished career, and they begin to do very uncharacteristic things, and trying to understand that when the symptoms are not recognized early or quickly as being related to a neurodegenerative disease can be very difficult. And the diseases are younger onset, so the typical average age of onset, as Bridget mentioned, is for people in their 40s to 60s. I believe the statistical average is right around in the mid-50s. So if you think about what's happening for somebody at this stage of their life, they are typically employed, typically at the peak of their career and their earning power, which means that that FTD comes with a lot of financial challenges where there's lost income and other healthcare issues that maybe have not been anticipated at the age at which the services are needed. The family dynamics at this stage of life are pretty complicated. Again, you may have children at home, you may have children who are in college or are on the cusp of emancipating as young adults, and people might be taking care of older adults, their parents as well. And a third factor in terms of the age of onset is that we're also talking about a population where people are still physically active and robust. They tend to have fewer comorbid health issues that would limit mobility or compromise their health. So we're talking about somebody who may be developing very poor judgment or other types of symptoms that impair their ability to function, but they look healthy. It's hard for other people to see that these are symptoms of an illness, and the person otherwise seems to be fine, which contributes to a significant amount of confusion. So the three pieces together really create what we call, unfortunately, a perfect storm in terms of the stress level for the family that's affected and the level of isolation. And there have been studies done in the realm of dementia that document that where the symptoms, where the person has a younger onset of dementia and the symptoms are more behavioral in nature, that the level of stress, the care burden, if you will, on the family is much higher. And we do see this in FTD without a doubt. The other important thing here is that FTD impacts the entire family system. So again, when it hits at a younger age and folks are at the peak of their career and family life, the ramifications are quite significant. And so the impact of the delayed diagnosis is really often destructive in many ways. So there's a lot of confusion around, is this what is this? Is this because the person doesn't love me anymore, or because they're just having a midlife crisis, or is it depression that's being treated but not treated effectively? The explanation is lacking for the symptoms, which means that people have actually had to cope with changing behavior long before it's diagnosed. And some of the symptoms, especially of behavioral variant FTD, where the person is losing some aspect of judgment and decision making, that's where often we'll see loss of finances, or they become very vulnerable to scams, to fraud, or impulsive spending. And judgment can lead to real complications from the behavioral standpoint before the disease is diagnosed, and that can be a really a concern and difficult for the family to be managing through. The developmental stage of the family, again, we mentioned. One of the really significant things here is that life roles change. So the roles that people have been playing up to date through midlife in terms of roles of working outside the home or taking care of things, managing the home, a lot of times there's an early need for those kinds of roles and household tasks to change. If someone's having difficulty with financing, or their executive functioning isn't allowing them to manage the children's schedules, and they're having, this is the area where difficulties show up, then you see the real ripple effects throughout the whole family system. The isolation factor is that these are symptoms that are not recognized as illness, and can be very, very difficult on a day-to-day basis when the people closest to the person with FTD are really keenly aware of the level of change and the impact of the disease, but folks around them don't understand. So if somebody begins to use bad language, or they are much more intrusive or ask inappropriate questions, the folks around them generally are not going to think that this is dementia or that this is a neurological disease. They're going to think the person's kind of a jerk. And so the family who's living with this and understands the nature of the disease has some really challenging issues to confront about their ability, their willingness to disclose the seriousness of the disease. When do they do that? How much do they say? Some of the behaviors can be very embarrassing, and so they need a lot of support and a lot of assistance. Oftentimes it does mean that the level of isolation for those folks increases tremendously. Again, the need for early planning financially and around legal issues is significant. Sometimes the behaviors of behavioral FTD do land people in, bring them to the attention of the police or the judicial system. There's been some studies that indicate that there are folks who maybe have their first encounter with the legal system in midlife through petty shoplifting or theft and things like that, that may actually be early indicators of FTD, but are not being identified through the healthcare system, but rather through the legal system. And of course, the legal system yet does not understand these diseases well, and so it doesn't necessarily accelerate the ability to get a diagnosis. And then thirdly, on this slide, the services that are available in the community are generally those available and designed for people with Alzheimer's disease. So the services and the care strategies are designed for an older population, and they are focused more on helping people to mediate the loss of memory and related behaviors, but not necessarily on the particular FTD types of symptoms that we see. And so different strategies are needed to address especially compulsive behaviors or repetitive behaviors, as well as the apathy. And the slide that Bridget showed on the impact of the social brain, one of the really most especially challenging aspects of the disease is this loss of relationship. And so the loss of empathy, that someone with FTD truly, because of the disease, loses their ability to feel with other people and to be able to put themselves in the shoes of other folks. And so you do see an awful lot of toll on the relationships as the disease unfolds. The psychosocial needs in this situation are very complex. So the best intervention without medications or pharmacological treatment, the best intervention is a well-informed, empowered caregiver and a well-informed and empowered person with the disease. Traditionally, FTD services and research have focused almost exclusively on supporting the caregiver, and it's really only been much more recently that we have been able to benefit from learning from people like Susan Sushin, who you heard in the beginning, where the person with the disease is taking a much more empowered role in some instances. You know, there are a variety of ways that FTD presents, and in many cases, people with behavioral FTD may not be aware that they're ill. The toll there almost entirely falls to the caregiver to arrange services and be able to pursue diagnosis and make sure the person is kept safe. But there is a portion of folks with FTD who are aware of their changing behavior, and those folks as advocates have become very valuable here. Regardless, it's really critical that the person with the disease and their family are perceived as equal recipients of the services because of the burden of care and because of the nature of the isolation that folks are experiencing. So partnerships and a team approach are really critical in services throughout the range of the care network. Disease education, again, that isolation and that lack of understanding in general means that finding particular information about FTD is really challenging for folks. It's still very common that we hear on our helpline people calling and saying, the doctor said that this is FTD, and they said there's nothing they can do, and that I should go get my affairs in order. Well, we now know that this is no longer true, that there is tremendous power in helping people to understand about the diagnosis, to understand about the disease, and again, to understand ways of living as well as possible with this diagnosis. And so that's a larger focus of our attention is going in that direction. How can we develop services and supports that will help people to live with quality of life throughout the course of this disease? The legal and financial planning is also, again, critical, that people understand the trajectory of a neurodegenerative disease. There is a lot of frustration in that we can't necessarily predict for any one person what the course of the disease will be. But the overarching arc of it is important for people to understand so that they can take steps to plan and to put in decision-making powers as well as financial planning and end-of-life planning as early as possible in order to maximize the participation of the person with the disease. And there's a tremendous need for additional attention to specific symptom management strategies and tools that will address the symptoms of FTD. Advocacy for benefits. Many folks who are below the age of 65 are not necessarily eligible for the services that come through our aging network. And so there's a lot of need for advocacy on behalf of folks with FTD and their families in order to access entitlement benefits, retirement, disability benefits, Medicare, Medicaid. Again, in the context of a disease that is not well recognized and not well understood, the need for this advocacy becomes even more critical. The lack of FTD-aware services in the community network is also very important. We know now that there are lots of benefits from occupational therapy speech therapy and physical therapy that people with FTD disorders can benefit from. Having appropriate referrals and assistance to access them is one of the great needs that exists. Home care, creative home companion services are all very important, and adequate training for those caregivers to understand how FTD is different from more common types of dementia is really important. Many people do benefit from adult day programs in order to have a structured routine, a productive engagement, and opportunities for them to have social engagement. It also provides respite for the caregiver, which can be very helpful. And again, finding the match of a day program where the person themselves might be younger than all the other folks in the program, or the majority of the people in the program. They're more active, more physically able. Their needs are going to be quite different from folks in a traditional adult day program. And so flexibility in the care services is really important. And then as people progress in the disease, a large number of folks will need assisted living or nursing care in order to provide the best service environment, the best quality of care for their needs, and in order to support the caregiver as well, the family caregiver. And then, of course, we know that hospice is an important service for later in life, at end-of-life planning. Apologize, my slides are not moving. There we go. So in order to just introduce you to a couple of resources that are available through our organization and elsewhere that can be helpful with families where they're facing FTD. So we do provide information, education, and support to folks who are facing an FTD disorder. We have a helpline that is not a crisis line, but it is available. People can call into the 866 number, the toll-free number, or email us. We will provide individual responses to their questions from staff members who have experience in the diseases, and try to connect them with information and supports as much as possible. We have two websites. Our main website is the first URL listed there. The second one is a great resource for people who have children or grandchildren trying to understand the types of FTD symptoms they may see in a loved one. And then we have an array of publications that are available as well that we can send out to folks. I apologize. I want to make sure we come back here, because this is the slide where we mentioned support. And having access to FTD-specific support groups and FTD-specific caregivers is really important. And one of the things Bridget has done with our organization is develop an entire network of affiliated FTD groups where the facilitators are receiving training and support through our organization on an ongoing basis, in order to make sure that the resources and the strategies and the particular approach to the support group is tailored to the needs of this population. So we currently have about 60 support groups across the US. There are 2 AFTD affiliated support groups in Colorado, and we are adding more groups all the time. We also offer some phone groups where there's a particular need among our stakeholders that is not met generally. And so again, we have a group here for people who have young children at home and a spouse or a partner who's diagnosed with FTD. We have a group for people who are facing FTD MND, they're caregiving for somebody with FTD and ALS, or motor neuron disease. We also offer some supports for the person diagnosed with FTD. And so these are all things that can bring people together from across the country using technology. We keep them small, so that they're targeted on the needs of those folks, but it allows our organization to both learn from their needs as well as to meet and provide support. AFTD provides a specific education conference every year, and we move that around the country. Next year's conference will be in Chicago. We provide modest direct financial assistance to caregivers and persons diagnosed through respite and travel grants if they're trying to attend an FTD conference to learn more about the diagnosis. And then we provide informal connections to try to find ways that people can meet each other, because again, we do know that being able to match the experience of caregivers when they're looking for support is really critical, so that it's the best match possible. I had mentioned before that we are advancing the involvement that we have with people living with FTD, and that has included a number of things, including the phone support group that we offer. We have more folks with FTD who are involved with us as volunteers who are beginning to speak out and tell their stories more to advance advocacy. We have an advisory committee of folks with FTD who are helping AFTD to learn more about how we can be more responsive to this part of our constituency. And we're beginning an innovative pilot program of quality of life grants, which will provide modest financial assistance to the person diagnosed in order to help them access some supports or resources that they're not able to get to otherwise. And then we're also bringing the various parts of our mission together so that we're helping people who are interested in participating in research get connected increasingly and have an increasing involvement and role in the development of clinical studies and trying to bring more drugs into the clinic to be able to be tested. And so the AFTD, as the hub of our community, is able to kind of connect the folks who are developing clinical drug studies as well as bring patients to the table who are interested in participating in this way. And then our Partners in FTD Care Initiative, which is what you see here, is a specific initiative for healthcare professionals. We do a quarterly newsletter that's case-based. It's developed with a committee of very dedicated clinicians who are experts in the field, and we try to provide context for a particular issue around FTD, as well as then practical intervention strategies and tools that people can use in a community setting. These are things that we generally will distribute through our mailing list, as well as try to use a real grassroots approach so that families can also take them to the providers from whom they're asking for assistance as a way of expanding the education of professionals and the empowerment of our families. And then we wanted to just make sure that we have time to answer some of your questions. So I think I'm going to pause at this point and maybe ask Phil and Devin to let us know if there's things in particular that we can speak to that folks are interested in.
You bet. Thanks for the presentation, Bridget and Sharon. Is a lot of information there, so we appreciate that. One thing I want to point out, folks, is there's a handout. There's a set of handouts that Sharon and Bridget and the organization provide that you guys can download, and we'll also have these available on the website. But if you have a desire to do that, you can download those at any time while we're going through the rest of the conversation here. You can also pose questions through the question tab that's there or the chat tab, whichever is more convenient for you. We do have a question from David. Would you say FTD affects cognitive abilities first, then physical abilities are affected next? How is there an approach on that?
So that's a really good question, David. Thank you. You know, it's a very complex set of disorders, and what we know is that people will present with different symptoms. It can depend on the subtype. It can depend, as Bridget said, on the very particular part of the brain that's affected. So in general, we think of FTD as being a cognitive and a behavioral disorder. There are folks with those motor subtypes who present with motor or physical changes first. So there are people with PSP or CBD that may be identified first and diagnosed first through a Parkinson's disorder clinic or a movement disorders clinic. And then that diagnosis over time may become more apparent that it has also cognitive involvement and the location in the brain is in fact PSP or CBD. Generally, for folks with the language disorders and the behavioral disorders, they would be presenting first with those types of symptoms. So the three different types of clinical presentations are really, so the motor symptoms, the behavioral symptoms, and the language symptoms. Those clinical presentation types are usually identified by the symptoms that show up first and are most prominent in the first couple of years of the diagnosis. But then as the disease spreads in the brain over time, you'll see symptoms coming in of the other presentations.
We also have a question from Valerie. You're providing a critical service by educating about FTD and helping people find resources and support to deal with this. She just wanted to say thank you. How do you find a physician who can recognize FTD?
So I can jump in on that one. So on a couple things, we know that on a community level, the majority of neurologists and most primary doctors aren't familiar enough in terms of all of those complications with diagnosing. And so on our website, we actually have for each region the closest medical center that has an FTD specialty. They're oftentimes the research hubs, so they are part of the academic centers related to different colleges and medical schools that also have the clinics there. Sometimes it's through the Alzheimer's centers that they exist, so don't be fooled by the name if it has an Alzheimer's name in it. If it's on our website, it does have the specific FTD focus. But in general, it's kind of hit or miss on the community level. If there are a lot of really great neurologists who aren't specializing in that can recognize it, and oftentimes they will send you to the academic center as well for diagnostics. But that's the easiest way is to look on our website for those clinics.
Okay. I'm just typing in some answers here. So, are you finding that when you showed that spectrum for everything that's kind of associated with Alzheimer's, does FTD get misdiagnosed quite a bit as far as, do they get maybe slotted into a different disease state, or maybe not even diagnosed correctly right out of the gate? You mentioned ALS. I mean, are you finding people diagnosed with ALS and maybe it was FTD, or what are you seeing there?
So I think it's really important to kind of underscore that we know that it usually takes people visits to 2 or 3 or 4 doctors over the course of maybe as much as 3 years before they're getting a diagnosis of FTD. So misdiagnoses are very, very common. And that's where, the early symptoms, especially of behavioral FTD, are generally going to be misdiagnosed as depression, bipolar disorder, midlife crisis, not recognized as a neurological disorder. And this is one of the greatest challenges that we have. So absolutely. The confusion between FTD and ALS, so there was several years ago, probably going back, it's longer than I think, maybe 7 or 8 years, the researchers identified a genetic mutation that appears in some cases of FTD and some cases of ALS, and actually links the two diseases. There is a portion, as that slide showed, there's a portion of our community where folks have both FTD and ALS. That particular genetic mutation has become really well researched. There's a lot of interest in trying to understand this better, because what the scientists find in that particular case is that that genetic mutation, people may develop FTD symptoms first, or they may develop ALS symptoms first, and they don't really understand what the connection between the phenotype and the pathology is. They're trying to study that further. One of the other things we didn't really get to, because it underscores the complicated nature of the diseases, is that there are multiple pathologies that result in the clinical presentations that we introduced. So it is not one disease. It really is a cluster of different diseases with several different pathologies underlying them and several different potential genetic mutations, but really only a portion of FTD cases are connected to a genetic inheritance. And so the level of complication increases dramatically, and there's lots of permutations. So the best advice really is for individuals to learn what they can about the disease and then try to apply what is most pertinent in their own situations.
Okay. When we were watching Susan's presentation, one of the things I thought was interesting, and maybe you can speak to this, there were times when you really couldn't tell that she had any issues. Her speaking was very clear and concise, and she seemed to have no problems at all. And then there, in a stage there, it looked like she was struggling to find the words. Is that pretty common, or, what do you, I'm assuming it's kind of a variant of all across the board, but.
So yes, and I think, from the family's experience, the level of frustration and confusion about the variability that's seen, especially early on, is huge, as well as for the person diagnosed. Folks with FTD don't look sick. They don't look sick to their family members or to the community members. They look healthy and robust. lay on top of that, that what we know about how a brain disease starts is it starts in one small part of the brain. We only recognize symptoms when enough brain cells have died in that area that the functioning becomes impaired. And so, over time that increases and you'll have more symptoms. The specific symptoms that a person develops is going to vary from person to person. And then people it's not like the brain cells die and the function is gone. Our brains are really complex. So there's some redundancy that allows us to function and figure out other ways to do some of the same things for a period of time. So in the early and middle stages of the disease, people have inconsistencies. They can have good days and bad days. We'll hear about good days and bad days. And they can be dramatic, where especially early on, people can seem as though they're functioning pretty well. They're working, and yet the family members closest to them will recognize that there's something that's just not quite right. Something fundamental is different and changed in uncharacteristic ways for that person. But it's not, there's no hard line where one day they're functioning well and the next day they're not. So there's a lot of variability. And there are times where people, folks will say, people with FTD will say, I do much better in the morning because I'm fresh. And so some people with PPA or the aphasia will be able to speak much more fluently in the morning when they're not tired, but as they get more tired, their language becomes more impaired. So there's a tremendous amount of variability, which, as you can imagine from the standpoint of living with this diagnosis, is really quite challenging.
Yeah, I can see that. What are you guys seeing in the areas of research for either a cure for FTD or even better symptom control? Are you seeing anything on the horizon from a research standpoint?
So we didn't include it here, but there's a slide that we love about the level of activity in FTD research, which is simply the number of publications over the past decade. And what you would see on a bar graph is that it's increased astronomically and consistently. So the research community is very interested in FTD, and there's several reasons why that interest is increasing. I mentioned the discovery of the gene that connects FTD and ALS. So one factor is that while the percentage of people who have inherited FTD is relatively small, it's about 12 to 15% of FTD cases are connected to an inherited mutation. But that percentage is actually higher than in Alzheimer's disease, where it's about 3% of the people have inherited a genetic mutation for Alzheimer's disease. So the families where there is a familial FTD mutation identified, they really are driving research in this disease. And so there is an interest in the research community to work with those families who are willing to learn as much as we can from the genetics of the disease, which is really advancing our understanding pretty quickly. That's not yet translated into large-scale clinical trials. There are starting to be a few. Being able to design a trial in FTD is pretty challenging because of the variability and because of the difficulty of knowing what's the pathological diagnosis underneath. But we're moving very quickly in that direction. So AFTD's mission is both the care and the cure. And on the cure side, we are able to be in a position of bringing together pharmaceutical companies and academic researchers and regulators to try to move that forward. The researchers are really excited and optimistic that they're making good progress. Translating that for the kinds of treatments that you're mentioning for symptoms or for a cure, of course, always takes longer than we would like.
Okay. And then you mentioned some of the medical insurance and support efforts that are out there to try to help this population. What are you seeing as from the coverage and assistance with state Medicaid programs around the country? What are you seeing, are they supporting this population, or what are you seeing from that perspective?
I would say, progress comes slowly on those kinds of benefits, and the one piece that we made headway on is it now is part of the compassionate allowances, so it basically expedites being able to get the services, but again, because of the early onset nature of the disorder, most folks either aren't close to being 65, or if they are, they maybe don't have the work experience needed to be able to tap into the benefits. So obviously each state is a little bit different in what that looks like, but it can mean a lot of out-of-pocket expense. And there was a economic burden study that was just done that, you know, the results aren't back yet in terms of exactly what that looks like, beyond knowing that it is a huge expense to the family. And again, it's not only that you're not eligible for the benefits, but it's also that you're no longer getting the income. So as Sharon had mentioned, we're typically at the diagnostic range where our folks are at the peak of their careers and at the peak of their incomes, and then they lose that when they have to retire or are forced out because of the symptoms of the disorder. And so it does create a lot of you know, really being creative. And you can apply for disability. It often takes a really long time because people look healthy, because they don't look like they have anything wrong with them. As we mentioned, a lot of those evaluations, it's, you know, 2 or 3 or 4 times back, and then they get denied. So the one place that we've seen that there is actually some progress with that is actually the hospice benefit. So you don't have to be on anything necessarily, right? So any benefits to be able to benefit from hospice beyond your own insurance, or you know, you can access it through Medicaid or Medicare. So that's been successful in terms of you know, creating that awareness piece where even though it's maybe not 6 months, it's a different criteria set for dementia. And so once that education happens, most hospices you know, are willing to work with our families and do what they can in terms of that, in that regard, to make sure that they get services. There still might be some out-of-pocket cost to that, but it's not nearly as expensive as, say, a facility or other places where it's completely out of pocket.
So,
Okay.
and yeah, I don't know if I just wanted to add, you know, the idea that in some cases states will have Medicaid waivers, and I don't know if that was part of your question, Phil, but there's no, like, the numbers are so small with FTD so far, and the advocacy, especially at the state level, is in such an early stage that I'm not aware of any place that has a waiver that's covering folks with FTD to be able to access Medicaid or state level services through that. And that becomes part of the challenge, because if people are too young for aging services, but that's what they need, there's a tremendous amount of advocacy that has to happen to educate providers around understanding FTD, and then to be able to get access to those services.
Okay. Bridget, if we wanted to, or we knew somebody that wanted to start a support group for FTD, you know, in Colorado, how would we go about, you know, either working with you, or how would that process go to, you know, get a support group set up in a place where maybe it's not currently available?
Sure. So we do it pretty streamlined way. Basically, the helpline number that was up on the screen earlier is the best place to start from this perspective in this context. So contact the helpline and let them know that, you know, you're interested in starting one, and then we get the process rolling. So basically, you would become a volunteer for AFTD, and as such we would provide you all of the materials, the training, kind of all of the different pieces. You don't necessarily have to have you know, explicit experience running a group, and you know, we kind of will work with you to make sure that you get what you need from that context. It's not a good fit for everyone, but for the most part, you know, we're willing to work with folks if they don't have that explicit training. And then from there, we also can do things like look in our database to make sure that, you know, there's enough people that can support the group, so enough members that would be interested, and we'll reach out to them on your behalf and make sure that, you know, it's going to be a viable group, and then we can kind of go from there with, you know, choosing the location and all of that. So the starting point is, you know, letting us know that that's something that you're interested in, and then we'll kind of walk through those steps. But it's already an outlined process that you know, we have streamlined here, and the first part of that is becoming a volunteer with us. So all of the trainings that we offer are also web-based in the same module like this one, because, you know, we are so spread out across the country. So we try to make it as convenient for people as we can to kind of you know, take part in that process.
Do you guys do a lot of work, or I guess work together with the Alzheimer's associations around the country, or how's that relationship?
So we do. There are several of our groups that are co-affiliated with the Alzheimer's Association. So we know that what we can offer and what the Alzheimer's Association offers don't need to be mutually exclusive. And oftentimes, on a local level, the Alzheimer's Association has a lot of really great resources, from doctors to facilities, home health, and those more local pieces. And what we add to that is, that specificity of, what the needs are as they are in context of FTD, and so it works pretty well that we do have these co-affiliated groups.
How do you guys see like an organization such as People Care, where we're a non-medical home care agency? How do you guys see us working with the FTD community, and better supporting the community as a whole?
Well, there's a lot of reasons why non-medical home care is really critical as a service to our community. As people have, what happens in behavioral FTD is very often people are trying to maximize the length of time that someone can be served at home with a good quality of life and safely. But we know that there's a real need for supervision for the person. They may not need medical home health care services as we tend to think of them, but companion care kinds of things are really important. Again, very difficult to access because they're out-of-pocket costs. But to be able to begin to develop a cadre of caregivers in the community who are interested and able to help families with companion care, with activity engagement, to give the main family caregiver some respite is tremendous. And so there's a huge role for it. That's where things like our Partners in FTD Care Initiative could be an easy way for folks to begin to get connected with and learning more about FTD. And then as there's needs in your community where people are looking for help along those lines, the respite grants that we mentioned, part of the design of those respite grants is to help defray the cost of companion care or defray the cost of adult daycare. It's not going to go far. We're talking about $500 that people can get. So it doesn't go far, but it's part of our commitment to help make that happen, because we know that if the family caregiver gets some support and gets some respite, and they can feel confident about bringing in people who are interested in learning and have a basic understanding of care, that it's tremendously valuable. The cost of assisted living is prohibitive for many people with FTD, and that's the first entry level for out-of-home care. So there's a huge financial interest in trying to help keep people stay as long as possible at home, as well as just for the overall quality of life and relationship between the person with the disease and the caregiver. And so it's a huge need.
I would also jump in there and say, from a staff level, a little bit of education can go a really long way. And so, the fact that most people, when they have people come in their house, it scares them a little bit because, for the caregivers and the families, particularly if there's a language barrier for the person diagnosed, and the person coming in says, I've never heard of that disease before, it doesn't kind of enact a lot of trust that, they're going to know what to do, even though they might. And so, just saying that I've heard of that before, and picking up one of our booklets or reading a little bit about it can go a really long way in terms of understanding what the needs of the family are. And so that's where, we come in and we have professionals call a lot on our helpline and ask questions about care. And that's where the partners that Sharon was talking about earlier in FTD Care came out of that need. So it can go a long way just to do a little bit of some educational piece for staff, so that they're not walking in saying we don't know about that.
And I would just add too, we didn't really get to talk about treatment or approaches to treatment a whole lot. There are medications that are used to be symptom specific. They're not approved in FTD, but there are a lot of the SSRI antidepressant medications may be used to try to treat particular symptoms. But by far, the vast majority of effective interventions are behavioral and environmental. And so there's a real opportunity for folks working in the field like your staff, if they're interested in expanding their skill set and begin to learn different types of behavioral interventions that will address the specific FTD symptoms, it's a great thing from a professional toolkit standpoint for them as well, because the need isn't going to go away. And so to be able to recognize that there are different types of dementia, and each of those different types of dementia may require certain types of skills, that's a good professional move as well.
Okay, great. Well, I'm not seeing any other questions, and we're closing in at just about an hour, a little over an hour. If there's any other questions out there, go ahead and shoot them across on the question sheet or the chat box, whichever is more appropriate, and we can go ahead and get those answered. I'm not seeing anything pop right away. So is there any closing comments, Bridget or Sharon, that you guys would like to make?
Bridget?
Sure. So obviously, thank you for everyone for joining us today and being present to this. And again, we know that on a community level, the majority of people don't know what FTD is, and so it really does take these types of webinars and awareness opportunities to be able to spread the word. And we at AFTD do have a whole host of information to get more educated about it. So if you're interested, definitely give us a call or email on the helpline that Sharon had up earlier, and we can try to connect you. But in the meantime, thanks for listening and being present to the presentation and learning a little bit more about FTD.
Great. Well, thank you, Sharon and Bridget. We really appreciate you guys taking some time to educate us all on FTD. Again, in the handouts section of the webinar, there are 4 handouts. We will have those available under our resources tab on the website. So if you want those or you need more information, obviously download those. Go to the FTD website. It sounds like there's a ton of information out there. Or reach out to the helpline, and you can garner more education. Again, thank you. This is Phil Gibson with People Care Health Services. Our next Community Connections discussion will be on July 12th, same time at 1 p.m., and Devin will be sending out the invitations and the information associated with that a few weeks in advance. So again, thank you, Sharon and Bridget. We appreciate your time, and everybody have a great day.
Thanks very much. Nice to be with you.
Take care.